Okay, welcome back. It is 12:15 Eastern Standard Time here in Toronto, and we shall start the webinar. My name is Dr. David Kanashko. I'm the Director of Education and Training and Research here at Meditech. We manufacture BioFlex laser therapy, and today's webinar is on laser therapy for alopecia. Before we get started, I wanted to say a few things. If you have any questions about what I'm presenting or just in general about the topic, please type in your questions. At the end of the webinar, I'll have time to go over those questions with you. And that this webinar is being recorded, and usually within a week or so of its broadcast date, it will be reposted on YouTube and sent out to everyone that's registered, or you can get a hold of it on our support page, which is password protected. All right, so let's get started. The reason why I want to do this topic is I do tend to get a lot of questions about treating hair loss and if it's effective. A lot of people read different things on the internet and they're not quite sure as to its efficacy and how you would approach treatment, and if it's in fact something clinically that you might want to do on some of your patients. So hopefully this webinar answers those questions. I try to do it in a relatively scientific, evidence-based manner, which I hope you appreciate. So I'm going to talk a bit about the hair growth cycle, the different types of alopecia, certainly the more common types of alopecia, and how LLT or photobiomodulation therapy is hypothetically or how it's thought to be helpful for this condition. There is actually quite a bit of research on this topic, so I have quite a few articles that I was able to go through, and some of which I will share with you, some clinical trials, which hopefully you find interesting. Then I'll give you some tidbits of information about how you might use our equipment specifically for treating alopecia. I do have a case study from one of our BioFlex users, so I thought it was quite interesting case study she presented at our last masterclass, so I took components of that just to show you a nice little case study, and then time at the end for some Q&A. So hair is one of the fastest growing tissues in the human body. I'm sure you're probably aware of that. It does undergo quite a bit of repetitive and regenerative cyclical changes as follows. They're named according to the three types of phases. The first one and the longest one is anagen, which is active hair growth. This can last anywhere from 2 all the way up to 6 or so years, and approximately 80 to 85% of your hair that's on your head is in this growing cycle. So that's anagen. Catagen is essentially involution, where the hair follicle starts to kind of shrink up. This starts to occur over a period of a couple or 3 weeks, and it begins the process of a new hair follicle renewing itself. And then telogen is essentially a resting or dormant phase of hair growth, and this is approximately 12 to 20% of your hair at any given time on your head are in this resting or dormant phase where it's not undergoing active growth. So those are the three cycles of hair growth. Diagrammatically, you can see them here. The first one, anagen, as I mentioned, where you have a nice root bulb and supporting cells in the follicle, and then of course the hair itself growing over a period of several years. Then you can see that it starts to involute and sort of shrink up. I think it's referred to as club hair at this point, so it's quite weakened. And you can see at the bottom here, the sort of red gloopy area, it's the beginnings of something called a dermal papilla, which are essentially stem cells ready to form a new hair follicle and turn into what's called secondary germ cells. And then we get into this telogen stage, which is kind of resting stage, and then this hair kind of dies out, and then you have the new hair coming up, and then the new growth turning into the anagen stage again. So that's essentially what's happening with your hair. So the types of alopecia, there's quite a few, but I'm just going to talk about some of the most common ones. And by far the most common one is androgenetic or androgenic alopecia, or AGA. It is the most common. Up to 50% of the male population will have the genes that trigger this. And essentially it's related to testosterone levels. Testosterone in the body is converted to something called dihydrotestosterone, or DHT. And what's interesting is DHT stimulates hair growth in everywhere in the human body, especially males, except for the head. So your axillary, your pubic region, other areas, those are all stimulated by DHT. But DHT present in the hair follicles is actually detrimental and can actually cause that hair to start to die. So essentially it's DHT that is the culprit. It binds to androgen receptors in the hair follicles that surround the hair follicle, and this will potentially trigger their deterioration over a period of time. Unfortunately, this process isn't well understood. There's obviously a fair amount of research going on in the field because it is, for some people, problematic. So what happens in androgenic genetic or genic alopecia? You can see here the DHT binding to the receptors as it's being produced in the male typically. And this will eventually, over a period of time, start to cause the hair follicle to shrink or recess. And the blood vessel supply starts to be diminished, and eventually you start to get reduced nutrients to the hair follicle, and the hair follicle starts to die off and fall out. So that is androgenetic alopecia. And there's different forms, different types, genetic variations. I'm sure that you're all aware of that. Here's just a little schematic to show you some of the different types. Another type of alopecia, and this is the one that the case study I have is at the end of the webinar, alopecia areata, or sometimes called spot baldness. It's considered to be an autoimmune inflammatory condition. It is a transient condition, meaning that it tends not to be permanent, but it can take many months, if not a year or longer, to resolve. Sometimes it can affect the entire scalp. It does have a different name. I forget what the name is, but essentially it can affect the entire scalp, but that's a lot rarer than just sort of specific points or bald spots. So these spots are about the size of a coin, maybe like a loonie or toonie, sometimes larger. Excuse me. And they often, as I mentioned, start growing back within a few months up to a year, depending on circumstances. Again, the underlying mechanism seems to involve the immune-mediated destruction of the hair follicle, somewhat similar to other immuno-related conditions like even rheumatoid arthritis and so forth. It's basically the body attacking the hair follicle. The stats, roughly 1 to 2% of the population, this is in the USA stats, can be affected by this condition at any given time. It does affect males and females. An example given here of both, what it looks like. And the third type I want to mention, which again I get sometimes phone calls about whether or not it can be treated, is anagen effluvium hair loss, which is related to the use of chemicals, medications. Oftentimes the most common ones are the ones in chemotherapy used to treat cancer. They say the stats are roughly 65% of the patients that do receive chemotherapy will go on to develop alopecia, and this again tends to be temporary type of issue. Initially it causes a patchy hair loss, which often then will become a total hair loss. And the growth period, at which point it takes to grow that hair back, can be as long as 6 months or even longer. So I mentioned chemotherapy drugs, but other drugs can cause this hair loss as well too. Some of the known drugs that can cause this condition are alkylating agents, amphetamines, beta blockers. You can see that heparin, blood thinners, even vitamin A, and some other compounds, warfarin, can cause this condition. All right, well, that's enough of the introduction. What is the role of low-level laser therapy and hair loss? So interestingly enough, way back in the day, the grandfather or father, I suppose it should be grandfather, but anyway, the father of laser therapy, Professor Andre Mester, he was the one to actually first notice that red light, in this case, grew back hair on these mice. So if you look carefully, the control on the right and the mouse on the left, which actually had red laser, it was around 680, 690 nanometers in wavelength. Andre was actually trying to get rid of some embedded injected tumor cells and in the bellies of rats. He shaved the skin, or sorry, the fur or the hair off these mice. Then he used a red laser, hoping to eradicate the tumor cells. As we know, the story goes, the red laser was calibrated much lower than he anticipated, and the only thing he noticed was, compared to the control, the hair grew back faster. And so you fast forward to 2018, and believe it or not, LLLT can be a modality that can be helpful for hair loss. So photobiomodulation can stimulate follicular stem cells. I mentioned earlier that as a hair follicle dies, you start to get the regrowth of a new hair follicle. This essentially is a type of stem cell. We know that photobiomodulation can stimulate these stem cells by both causing an increase in proliferation of them and their differentiation. And this increases levels of something called heat shock proteins, which influence the regulation of the growth and the differentiation of hair follicles. So it's believed that PBMT, or photobiomodulation therapy, can stimulate the re-entry of telogen hair follicle into the anagen or growth phase. It's also believed it can bring about greater rates of proliferation in active anagen follicles and prevent the development of a premature catagen stage or involution stage. As well, they believe it can extend the duration or length of the anagen phase. So these are all mechanisms of action that they believe how LLLT can help with hair growth. So one of the most common ways of treating it with drugs anyway is minoxidil. This is fairly common. It used to be prescription, but now you can get it over the counter. The exact mechanism of this medication isn't really well understood. However, they do know that it contains nitric oxide. In fact, I believe it was, they noticed the effects initially because the drug was being used for heart conditions. And they noticed one of the side effects was hair growth in men that did have receding hair growth. So it was a kind of a positive side effect. And from that, they made it into a drug for hair growth. So it's nitric oxide. We know it's an important cellular signaling molecule, and it's also a vasodilator. And interestingly, we know that PBMT increases levels of nitric oxide, so we believe that it might also be in part through this mechanism of increased nitric oxide that has a beneficial effect on hair follicles. It's also been demonstrated that low-level laser therapy can stimulate hair growth through modulation of inflammatory processes and immunological responses. This is especially true for alopecia areata, where it's known to be an immune issue and an inflammatory response. And we do know that LLLT can have an impact, a positive impact or immunomodulating impact on white blood cells. So since inflammatory infiltrates are involved in pathogenesis of AA or alopecia areata, LLLT might be able to play a significant role in the treatment of it and by modulating the effects of inflammation. And I do have a research paper on this topic. The first research paper is on androgenetic alopecia. This was done in females. They used photobiomodulation. 44 patients were treated. You can see here that they all had anywhere from type 1 or from stage 1 to 2 hair loss patterns according to this Ludwig-Savin baldness scale. You can see here 1 and 2. The hairs in the selected site were trimmed so they could observe them and take pictures of them. I believe they also did a little temporary tattoo to know the exact area. Then they used 272 5 milliwatt 650 nanometer diodes in kind of like a helmet kind of configuration. They treated for 30 minutes per day, every other day for 17 weeks. So you can see it's a fairly long and prolonged treatment. Again, that has to reflect with the growth cycle of hair. You can see the total milliwatts of power, 1360. Just have you note that this is pretty close to our dual red array and the dual 240 configuration. And they pulsed it at 6.92 hertz. I don't know why they did that, but interestingly enough, they actually pulsed it out. So that was interesting. So here's the before and after of two different cases. You can see before the treatment began and then after their series of treatments. You can see the increased density of hair in both of these before and after pictures. And their results were that they concluded that LLT of 650 nanometers, so in the red zone, if it's applied to the scalp every other day for 17 weeks, so they did 60 treatments in total, that it was very beneficial in increasing the hair density for these patients that used the device. Another one, another paper, 2013, the growth of human scalp hair mediated by visible red light laser and LED sources in males. They looked at 51 males, varying ages. Again, used 5 milliwatts combination lasers and 30 LEDs. Again, roughly 655 nanometers. Again, I just note that we use 660, so pretty close. Again, in a similar bicycle helmet-like apparatus. Patients were treated every other day, 16 weeks, 60 treatments in total. Continuous wave from what it appears. And there is also divided into placebo and treatment group. And again, you can see the before and afters showing you increased hair density. In number A, the hair counts were 140 at baseline, and they went to 280 or double that after the 16 weeks of treatment. And in B, it was 143 at the beginning and 322 at the end of treatment in this subject B. They also noted that some of the hair subjectively appeared to be thicker and more deeply pigmented after the treatment. So it's another nice clinical trial. This next one is efficacy and safety of male and female pattern hair loss, multi-centered sham device controlled double-blinded study, a much larger one, again using 655 nanometer wavelength. I hope you're getting the idea here. They're using red a lot more than infrared. I'll talk about that shortly. They treated the whole scalp 3 times a week for 26 weeks. Terminal hair density was evaluated both at 16 weeks and 26-week follow-up. Here's just one particular subject. Actually, it's 2 different people, but you can see here before and after, quite convincing and noticeable hair growth for this female in this case. And again, density before and after of improvement of the hair cycle. So they concluded that they detected a statistically significant increase in terminal hair density after 26 weeks of LLT compared to the placebo. They did notice, they said the improvement was independent of sex and age of the subject. The increase in terminal hair count was comparable to short-term trials of minoxidil. However, long-term, they felt it may be less effective than minoxidil if used long-term. However, of course, this was only done one short treatment time frame. So it makes sense that if you have a genetic issue, you're going to have to continuously treat yourself. This last one was done on mice, and the reason why I did that is because it was the only one I could find on alopecia areata. They looked at 12 mice. They were randomized into placebo or sham and treated using 655 nanometers, 20 seconds, 3 times per week for 6 weeks. I couldn't find the output of power for this paper. It didn't list it. I couldn't find it. And here you can see baseline, the area. So what they did was they heated up the skin to deactivate the heat shock proteins, and that caused a area of alopecia areata. So essentially, just so you understand here, if you followed this mouse over a period of time, that hair would stay would not grow back. Okay, it might possibly grow back after months, but it is essentially hair loss for a period of time. Then you can see 2 weeks, and sorry, this should be 4 weeks, my mistake, of LLT treatment. You can see the hair actually grew back completely. So the question might be, well, it's going to grow back anyway. In fact, it would, more than likely, but it would take months to do that, not weeks. So you can see nice results for AA or alopecia areata. So on histology, they increased the number of anagen hair follicles was observed on the laser-treated mice. On the other hand, the sham-treated mice demonstrated hair follicles in the telogen phase with no hair shaft, so it didn't have any effect. They didn't have a picture of the sham one, unfortunately, but I'm just going by what they reported. All right, so how does one go about using our equipment for this treatment? If you do have our equipment, you probably know we don't have protocols. We're not approved to market it in that way. However, we certainly do know enough about it that you could use our equipment for it in an off-label use. So what we recommend is using the flexible dual array, preferably the larger one, the 240, but if you have the 180, that will work as well too. Remember, the wavelength is 660 nanometers. It's flexible, so you want to make sure that you flex it over the area of scalp that you're treating. You should treat for longer periods of time, upwards of 10 minutes. You may want to adjust that even longer, depending if you're finding the patient responding or not. We do recommend that you take close-up photos before and perhaps photos every several weeks to monitor the progress. If you do have an LDR laser probe, you can also add that to the mix as well too, treating the affected areas. You may want to alter the treatment time based on the color or the melanin in the skin and the hair. So for example, if a patient has darker hair and skin, you'll want to increase the time, and the opposite, decreasing with lighter hair, blonder hair, and lighter skin color. Once in position, you want to move the array back and forth to move the hair follicles out of the way of the embedded SLD diodes. One of the advantages of our equipment is the fact that the diodes stick straight out of our equipment. They're not sort of recessed or embedded behind glass, in which case you have much poorer contact with tissue. In our equipment, they actually stick out like little tiny combs, and so if you move the array back and forth, you'll displace any hair around the area to make better contact with the scalp, and this will allow for better penetration of the light. Again, we recommend red light because red light concentrates in the epidermal layer where the hair is, as opposed to infrared, which will go through the epidermis and deeper down. It will be effective, but most of the research seems to focus on using red. Okay, a case study by one of our BioFlex users out in Alberta, Dr. Brandy Frenette. She had a scenario of a young lady presenting with unknown geographic hair loss. It was diagnosed as an autoimmune alopecia areata. I think Dr. Frenette mentioned another opinion on perhaps a parasitic issue, but regardless, it seemed to be an inflammatory, perhaps autoimmune issue of geographic hair loss. And so you can see one of the areas. There were several, I believe. The first area of involvement. There is kind of a redness here, and Dr. Brandy did note that that was really due to a birthmark, not due to pronounced inflammation. You can see here, this is before treatment, and you can see the area, again, a little bit clearer of hair loss. After one treatment, you can actually start to see some hair growth on November 21st. By December 24th, she had 2 treatments, and you can start to see hair growing back even more. And a little bit same time frame, but just a different viewpoint here of the hair. And after 3 treatments, quite pronounced hair growth. And in this case, there were just 6 treatments done, but you can see there was significant hair growing back about a month or so after this patient was treated. So in our clinic here, we tend not to do a lot of this work because we're not really doing cosmetic stuff, but based on the research, based on clinical anecdotes, it does seem to be quite effective. Dr. Frenette did use the red. She used it for 4 minutes. I did mention longer time frames. She pulsed it out at 50 hertz. That's fine if you want to try to frequencies. Really, the issue, I think, is just experimentation. You're not going to harm your patient, and it's certainly worth it trying. But see, she also added red laser probe Although she only did 4 minutes of the array, she did do the red laser probe, which would allow more energy into the area as well. Okay, so that is our webinar for today. Just to remind you, we have a certification training coming up in, this weekend here in Toronto for your last minute, but also in March 23rd, 24th here in Toronto, and in Vancouver, March 2nd and 3rd. If you care to join us, that would be great. And let's look to see if you guys have any questions. So I'm going to pull that out. And you have no questions. So obviously the webinar was pretty clear. So anyway, I thank you very much for joining me today. And our next webinar is on gout, and that's in March. I think it's the 22nd, but double check our website, bioflexlaser.com for that. And I will be posting a new series of webinars within the next week or so. Thanks for joining me, and have a great afternoon.